And I want to welcome you all to the very first webinar in the series of asthma and COPD. And as Sue said, before coming to Priority Health a year ago, I managed the local asthma coalition for 20 years. I worked for 9 years as a nurse practitioner in an allergy office. I have a daughter with asthma. I have asthma myself. In fact, I'm actually on a prednisone course right now for a recent asthma flare. So when I say that I live and breathe asthma every day, I truly live and breathe asthma every day. It is a passion of mine. And if I do need to put you on a brief mute, I will do so just to clear my throat. But I'm delighted to be here today to talk about asthma. And some of you may have participated in previous webinars that I've given on asthma and COPD. And for some of you, this may be new. For others, this may be a review, although I have really tried to incorporate the most up-to-date knowledge about asthma that has come out in 2017, as well as building on the evidence base that's been there for many years. So there may be some new points that you learn along the way as well that are even more recent than a year ago. And a lot of the new information comes from a new set of guidelines. Now, we're still functioning off the guidelines that were issued by the National Heart, Lung, and Blood Institute, the NHLBI, part of the National Institutes of Health, back in 2007. So that was 10 years ago. That is the most current U.S. guidelines for asthma that we still follow. However, there are no global guidelines that are available.
Hit exit full screen.
I think I'm hearing. There are global guidelines that are now available as well, and this comes from the Global Initiative for Asthma. These are known as the GINA guidelines, and these are updated more regularly. Now, these will incorporate some European thoughts as well as evidence, so this may be just maybe a little bit different than the guidelines from 10 years ago. Obviously, these are newer, and there's been a wealth of evidence in the past 10 years. So I'll be bouncing back and forth between these guidelines, trying to bring you the very, very newest of the evidence base around asthma management, asthma diagnosis as well. So you'll see some slides in here that reflect the GINA guidelines that are just an update of the national guidelines that are from 10 years ago. So we know that asthma places a tremendous burden on the worldwide population. There estimated 300 million people are affected across the world. The prevalence is increasing. That's not anything new in the U.S., but it's increasing worldwide. Asthma is a major cause of school and work absence, and the healthcare expenditures on asthma are very high. Whether you be a payer or a provider or an asthma educator in the community, we all recognize the fact that asthma places a tremendous burden on society, and the costs are ever increasing. We know that developed economies might expect to spend 1 to 2% of their total healthcare expenditures on asthma, and that developing economies are really facing increased demand because of this tremendous increase in prevalence. We know that poorly controlled asthma is very expensive, but we also know that if we can invest in prevention, if we can invest in education and helping people understand their condition and how to manage it properly, we know that's going to yield cost savings in emergency care and hospitalizations and asthma deaths. So in the United States, this is the most recent statistics that I have right now, just under 25 million Americans have asthma. Of those, about 6 million are children. And asthma is the most common chronic disorder in children, the most common chronic disorder in children. Children with asthma are 3 times more likely to miss school than those who don't have asthma, accounts for over almost 14 million days of school missed every year. Asthma is the 3rd leading cause of hospitalizations in children under 15. In Michigan, asthma is the leading cause of preventable hospitalizations, the leading cause of preventable hospitalizations. Every year, asthma accounts for 1.5 million ED visits, about 500,000 ED visits to children. And the economic costs are staggering, $56 billion spent every year, most of that in direct costs for medical care. Probably the largest single expenditure is pharmacy, which is over $6 billion. Now, when we talk about the prevalence rate, what we really are seeing is asthma, and this is no different from a year ago. Asthma is still approaching epidemic proportion, and I don't use that term loosely. I didn't use that term loosely a year ago. We are truly seeing an epidemic of asthma. The current prevalence rate is about 8.4%. In many areas, it's higher than that, as much as 10%. So in typical schools across the country, an average of 1 out of 10 school-age children has asthma. So in every classroom in the United States, if you have a classroom of 30 children, an average of 3 children in every classroom in the U.S. has asthma. I mean, that's just staggering when you think about it. Much higher prevalence among poor and minority populations. The prevalence is increasing. This is where that epidemic comes in. The number of people with asthma in the U.S. grew by 15% in the last decade, and the greatest rise in asthma rates is among Black children. They really are suffering a disproportionate burden, almost a 50% increase in just 8 years, from 2001 to 2009. So it's estimated that if we continue to increase the prevalence at this rate, worldwide asthma will grow by more than 100 million people in just another 8 years or so by 2025. And we are also seeing that asthma deaths continue every year, even with everything we know about asthma in 2017, with a brand new set of guidelines, the global guidelines, with the guidelines from the NHLBI, with highly, highly effective asthma medications and treatments. And we know how to mitigate environmental risks as well. And yet we're still seeing people die from asthma. We shouldn't see anyone die from asthma in 2017. There just should be no, asthma deaths should be eradicated, and unfortunately they're not. In fact, to the point that every day in America, there are on average 11 people who die from asthma. So this is just after noon and the East Coast or Eastern time. We probably have statistically seen 5 or 6 people die already today from asthma somewhere in the US. And that's just unconscionable. When this is a totally preventable death, virtually every asthma death is preventable. Virtually every asthma emergency department visit and every asthma hospitalization is preventable. We should be able to get asthma under control and keep it under control. In Michigan, we see 130 to 150 deaths every year. Of those, 10 to 15 are in children. So in Michigan, we have about 250,000 children and over 500,000 adults who currently have asthma. Over half the Michigan adults with asthma had an attack in the last year. 20% of Michigan adults with asthma are having asthma symptoms every day. Again, asthma should be a controllable disease. The hospitalization rates for asthma are highest in the very youngest children from 0 to 4. And again, we see that tremendous ethnic disparity. We see the hospitalization rates for Blacks are 4 times the rate for whites. And asthma deaths in children, fortunately, are rare, but not rare enough. They still occur. And we see asthma deaths in Black children at 6 times the rates of those in white children. So what do we know about asthma? We know that asthma can be effectively treated. It can be controlled. And when asthma is well controlled, we would expect that people with asthma should not have nighttime symptoms or daytime symptoms, should need little or no quick relief rescue medication, should have productive, physically active lives, should have normal or near normal lung function, and should avoid serious asthma flare-ups, also called exacerbations or severe attacks, that would warrant an emergency department visit, a hospitalization, an ICU stay, and certainly prevent an asthma death. So there have been certainly, just in the past 10, 20 years, a tremendous, both a local, a statewide, and a national response to this asthma epidemic, this asthma burden. One is the Asthma Initiative of Michigan, which includes the coalitions of which I used to be a part of, the Asthma Coalition of West Michigan, have formed a consortium of asthma coalitions, and there's a great website I just want to direct your attention to. It's called getasthmahelp.org. It's a wonderful state website, a repository of great information that is in compliance with the newest guidelines from the NHLBI, and it's great information for both patients and professionals alike. And if you want to see the statistics in your local communities, you can go on there and even sort by county and see what your prevalence rate is and what your hospitalization rate is and that sort of thing. The EPA, the U.S. Environmental Protection Agency, has hosted the National Asthma Forum, and also created a website of asthma programs nationwide. It's called asthmacommunitynetwork.org. So if you and your respective communities want to start an asthma program or is looking for an asthma program, instead of reinventing the wheel, I would invite you to go there, and there are hundreds of asthma programs around the country. There might already be one that exists that may be similar to what you are interested in creating, and don't start from scratch, but draw from the experience of others. And finally, the National Asthma Educator Certification Board. I am a past chair of this board. I'm an emeritus member of this board. This is the board that writes the national exam for individuals who wish to take this exam and become a certified asthma educator. There are about 200 certified asthma educators in Michigan, about 3,500 in the nation. You can visit naecb.org to find a certified asthma educator in your area. If you have an interest in becoming certified, you can always reach out to me and I can walk you through that process. And we are always looking to increase that bench of certified asthma educators around the country, certainly in our state as well, who can provide that evidence-based education to members of this very complex disease, but a disease that can be controlled with self-management education. So we're going to begin with a definition of asthma. And asthma is defined as a heterogeneous, which means it really is different in everybody. It's just a little bit different. Not everyone's asthma is the same. So my asthma is different than my daughter's asthma. My asthma is not even the same from one day to the next or 1 year to the next. So it's ever changing, but it is a chronic inflammatory disorder of the airways. And it's characterized by recurrent episodes of wheezing, shortness of breath, chest tightness or pain, and coughing. Those are the four hallmark symptoms of asthma. And in asthma, someone who has asthma, the airflow limitation is at least partially reversible. So you can reverse the track and you can open those airways again. And this is what differentiates somewhat from COPD, which is irreversible. But in someone who has asthma, the airways are hyper-responsive. They're very twitchy or irritable or super sensitive, and they react to a variety of stimuli or triggers. So in response to a trigger, and just using myself as an example, I just had a simple upper respiratory infection a week ago, and it didn't take more than a simple URI to, once the virus is long gone, it left asthma in its wake because it caused inflammation in my airways. So it will trigger that airway inflammation. It'll cause those bronchial smooth muscles to go into spasm and clamp down around the airways. It'll increase mucus production, so there's more phlegm. And the end result is the airways themselves become narrow and breathing becomes difficult. And that's when you develop asthma symptoms. So if I'll probably have heard this before, but I always say that if I were giving this talk, 30, 40 years ago, I'd be a lot younger, but also I'd be talking about asthma in the 70s in terms of bronchospasm. That's really all we knew about asthma 40, 50 years ago. Asthma was a disease of bronchospasm. We knew the airways clamped down, they tightened up. That's when Primatene Mist came on the market. People took bronchodilators, they opened up their airways, and they could breathe. But we have since learned in the 80s and even more in the 90s that asthma is not only a disease of bronchospasm, it's a disease of inflammation. Inflammation is the root cause of asthma symptoms. And so in the 90s, we learned that not only was it the bronchospasm and inflammation, but if that inflammation is allowed to go unchecked for years or decades, it can at some point become fixed airway obstruction, not unlike COPD. And that's called remodeling. And now, presently, we're looking at a very complex system of mediators. And that's why when you see new medications coming out, and there's a whole new pipeline of asthma medications, and we'll talk about some of those in the medication webinar, but there's going to be customized asthma medications that are coming out that are targeting specific mediators that really are focusing on an individual's genotype or phenotype that will be very customized care for an individual with asthma that could really turn the tide for many people who have difficulty with asthma. But you'll see how the knowledge about asthma has progressed through the decades. We know it's so much more now than just bronchospasm. Because again, the root cause of asthma is inflammation. Inflammation, inflammation, inflammation. I cannot emphasize that enough, and you'll hear me say that over and over again throughout these series of webinars, is inflammation. If we don't get the inflammation under control, we cannot get asthma under control and keep it under control. We just have to address inflammation because that inflammation causes those airways to be so hyperresponsive or twitchy. And then you add in the risk factors like upper respiratory infection, cold air, smoke, pet dander, whatever that may be, that leads to the airflow limitation and that leads to symptoms. So we have to address inflammation. So if you look at the cross-section here of an airway on the left, and this is what a normal airway should look like, and the airway lumen is open, and you can see there's plenty of room for air to move in and out, and this individual would not typically have any difficulty breathing, and you can see it's looking very normal. The one on the right was probably me a couple days ago when I was having some asthma symptoms, and the prednisone now has hopefully decreased that inflammation inside of my airways because I am breathing better. But you can see the inflammation, the airway wall becomes red and swollen and hot and angry looking. And you can see the muscle bands are tightening around the airways as well. They're clamping down and squeezing those airways. You can see the excess mucus production. You can see there's even air trapped in the alveoli here. And you can imagine trying to breathe through this airway rather than that airway. It's going to be much more difficult. And if you do hear wheezing, and a mom asked me once, well, how much wheezing is normal in asthma? And I said, no wheezing is normal. Wheezing is simply the sound of air trying to move through a very narrowed airway, and that's not normal. You want air to move through this nice, open, patent airway, and if it's moving through this narrowed airway, you're going to hear a wheeze. Now, this is looking through bronchoscopy. So a camera has been inserted into someone's airway who has asthma, and you can see the airway lumen here. And this person was then exposed to something that they were allergic to, and they took a photograph of the very same location just 10 minutes after they were exposed to that allergen challenge. And you can see the airway has been almost completely occluded. And that's how quickly it can happen. It can happen within minutes. It can happen within hours. It can happen within days. It just depends on how sensitive that person is or what the challenge was. But you can see how quickly that happens. So if you have a patient who is using albuterol, which is the rescue or quick relief medication, or reliever is another term that you might hear, they truly are treating just the tip of the iceberg. They are having symptoms, they use the reliever. They're having symptoms, they use their quick relief inhaler. And they're doing that over and over and over again. Can it be effective? Certainly. But are we treating the root cause? What is underlying the surface? Inflammation. The quick relief inhaler, you can use albuterol till the cows come home, and you're not going to address airway inflammation. Albuterol does nothing to fight inflammation. It simply relaxes the tight muscle bands around the airways, opens them up, and allows someone to breathe again. It does nothing to fight inflammation. So if the inflammation goes unchecked, that leads those airways to become hyperresponsive or twitchy or irritable. That leads to airflow obstruction, and that leads to symptoms. So how do we then go about and diagnose asthma? Well, we look at a couple of things that might increase the probability that someone would have asthma. And we talked about those hallmark symptoms: wheezing, shortness of breath, coughing, chest tightness. If someone has more than one of those types of symptoms, they have wheezing and shortness of breath, or coughing and wheezing, they might be more likely to have actually developing asthma. Are the symptoms worse at night or early in the morning? You know, I might cough a little bit during the day. I might cough a lot more at night because asthma is typically worse at night. Do the symptoms vary over time in an intensity? Like I said, my asthma is different from one day to the next, and the intensity is different from one day to the next. Are symptoms triggered by traditional asthma triggers, like viral infections, exercise, allergen exposure, weather changes? You know, the fall is a particularly challenging time for people who have asthma because the weather changes so dramatically. We had cold rain yesterday and sunny and warm today. It just, the variability in the temperature and the barometer and the humidity, all those things in springtime is another more challenging time. Laughter, just any change in the breathing rate, laughing or crying can actually trigger asthma symptoms. And then there are airway irritants like car exhaust fumes or cigarette smoke or strong smells. Any symptoms triggered by those traditional asthma triggers might again increase the probability that someone's symptoms are related to asthma. What might decrease the probability that symptoms are due to asthma is if they had just a cough and no other symptoms, or they have a lot of sputum production. We might be thinking maybe possibly more COPD. If they have shortness of breath that might be associated with dizziness or chest pain, then we might think possibly not as much due to asthma. So we look at factors that might predict that someone is developing asthma or has a history of asthma. We look at family history. Family history for asthma is very, very strong. I have asthma, my daughter has asthma. We look more, it's stronger on the mother's than the father's side, but either parent is certainly increases the risk in that child develop asthma. Is there a history of atopy, which is an allergic response to allergens? So have they had a positive skin prick test or positive blood test to aeroallergens like tree grass, weed, mold, dust mites, pollen, dander? Do they have a history of eczema, which is atopic dermatitis, or allergic rhinitis? There's actually a phenomenon known as the allergic march. So oftentimes babies who have that atopic or that allergic profile will develop eczema as a baby. And then as the child gets older and they've lived through pollen seasons, they develop sensitivity to pollens or to dogs or to foods. They might develop a rhinitis, allergic rhinitis. And it goes from eczema to rhinitis, and then the next step in that allergic march or allergic cascade is asthma. So sometimes it actually progresses in that way. Are they exposed to allergens such as dust mites or animals? Living with a dog, might that put them more at risk for developing asthma if they have that underlying allergic profile to begin with? Have they had viral infections? RSV, which is respiratory syncytial virus. Many, many, many babies get RSV virus. It's very, very common. In a baby who has that genetic predisposition to asthma, sometimes when they have that predisposition and they develop RSV, that will turn on the asthma switch and they'll develop asthma from that point forward. We see more asthma in boys than in girls, and then it equilibrates somewhat in adolescence, and then we tend to see more asthma in women than in men. As the boys grow up and their airways get larger, we tend to see more asthma in women. In smoking, are they exposed to smoking? Are they exposed to secondhand smoke? Do they themselves begin to smoke when they become adults? That is also a risk factor for developing asthma. But the strongest predictor that wheezing will develop into asthma is atopy, because we know that babies can wheeze and not have asthma. We know that people may wheeze and not have asthma, but the strongest predictor that wheezing actually translates into asthma is that link to allergy or the allergic response. So we assess symptoms, first of all. We look for those hallmark symptoms. Is there a history of coughing? Is there wheezing, dyspnea? Are there nocturnal symptoms? Does it affect activity? Now, sometimes, not everybody with asthma wheezes. Sometimes the only symptom you'll see or hear is a cough. They may have just a cough and no wheeze. We saw a woman when I worked in the allergy office who came in with a 20-year history of chronic cough. And she had no other symptoms than a chronic cough. And she had the $1 million workup and had been checked for so many things, and they could not find a reason for her cough. And we did classic spirometry, which is lung function test we'll talk about momentarily. And then we gave her a bronchodilator, repeated the lung function test in the office, and she had a significant improvement, which is a gold standard for diagnosing asthma. So we put her on asthma medications, and the cough went away after 20 years. So she had classic asthma, but no one thought that maybe just this cough, this chronic cough, is asthma. So not all coughing is due to asthma, but much of it is. So it's often, let's just rule it out. That's one of the first things I'd want to look at. If someone were complaining of a chronic cough, let's at least take it off the table, because it very well could be asthma. Coughing might be the only symptom present. But also a thorough medical history, physical exam, measure lung function, evaluate the allergic status. Certainly there could be alternative diagnoses as well. It could be cystic fibrosis, it could be GERD, it could be they've aspirated something. But more often than not, let's at least think about the possibility of asthma, because I will tell you, to this day, even 10 years after the US guidelines, and even though those global guidelines are coming out annually, almost annually, we are still seeing this tremendous burden of asthma. And part of the reason is because asthma is often underdiagnosed and undermanaged. It's not that there's too much asthma out there, or we're seeing too much, or we're calling too much of it asthma. There's not enough. We're not calling asthma when we actually see it. It's underdiagnosed and it's undermanaged. So if you see somebody who has a history of repeated coughing or wheezing or chest tightness, sometimes providers are reluctant to call asthma, so they will sometimes call it reactive airways disease or allergic bronchitis or wheezy bronchitis. I previously sat on a pediatric asthma mortality review panel. We looked at all the asthma fatalities in the state in children. We did that for a series of about 5 years running, and we would have their next of kin interviews and their autopsy reports. And there was one young girl who had been seen in the emergency department, and she had a fatal asthma attack about a month after her discharge from the ED, and cause of death on autopsy was a fatal asthma attack. Now, she had never been diagnosed with asthma, because every time she went to the emergency department, they called it wheezy bronchitis. They gave her a course of steroids and they sent her on her way. But the emergency department is probably not the best place to make that diagnosis, and she didn't have a primary care provider. So they were treating it, as best they could, but not calling it asthma, because they were not her provider, and she died from a fatal asthma attack without ever having been diagnosed. So that's an extreme example, but asthma is often underdiagnosed. So keep that in mind. And if the symptoms are worsened by viral infections, by smoke, by allergens, exercise, weather, again, traditional asthma triggers, let's think about the possibility of asthma. If symptoms worsen or occur at night, if there's reversible airflow limitation on spirometry, wheezing may or may not be present. You know, we would sometimes in the Asthma Coalition send a patient to the provider to confirm a diagnosis of asthma. Sometimes the provider would say, well, the patient wasn't wheezing, we couldn't diagnose asthma. Well, they may not have been wheezing at that moment, or they may never wheeze. It doesn't mean you can't diagnose asthma. It just means they weren't wheezing at that moment in time. And again, some people never wheeze. Physical exam to diagnose asthma, you may see someone coughing or wheezing. You might see prolonged forced expiration. They might be using accessory muscles. In children, you might see retractions, which is a sucking in of the skin above the breastbone or in between the ribs, and that's very common. You might see a hyperexpansion of the chest on X-ray. You might see signs of allergic disease. However, you can still diagnose asthma even if the physical exam is perfectly normal. Again, they can come in with a history of these symptoms. They may be perfectly fine when they're sitting in your office, and you can still diagnose asthma based on their history alone, and especially lung function if they're old enough to conduct that. So some things to think about in diagnosing asthma. Is there a history of cough, especially with exertion or breathing cold air? Cold air is another strong trigger for me. I'm a walker, and I can walk in the mall. I can walk 3 miles in the mall, and I don't cough once. But if I walk from the parking lot into my office and it's a cold, blustery day, I will have to cover my mouth, or I'll use my inhaler by the time I get into the office. Cold air is such a strong airway irritant that by the time I get in here, I will have difficulty breathing. So history of cough, and again at night as well. History of wheezing. And wheezing is just that tightness, that noisy breathing. If you've ever heard wheezing with a stethoscope, and typically it's difficult to hear it without a stethoscope, they're wheezing audibly. That's really quite alarming. But otherwise, if you listen with a stethoscope and you heard the wheezing, it's just a very high-pitched musical whistling sound. Sometimes if you have someone who's really in distress, you don't hear any wheezing, that's actually a danger sign. That means they're no longer moving enough air to wheeze, and respiratory arrest can be imminent. I took my daughter in once when she was much younger. She's an adult now, but we took her in, and I knew she was in distress, and she had what they called a closed chest. She wasn't moving enough air to wheeze. They gave her a treatment, and then her lungs opened up like a symphony. You could hear all the musical notes because she was starting to move air, and that was a good thing. So wheezing is that sound that you may or may not hear. And breathlessness, the shortness of breath, it could be intermittent, could be with exertion, it could be at night. But any one of these or any constellation of these symptoms, let's at least think about the possibility of asthma. Let's think about it. Rule it in, rule it out. Let's at least think about it. Now, I will grant you it is more challenging in children to make that diagnosis. I have heard some people say, well, you really can't diagnose asthma under the age of 2. You can diagnose asthma at any age. We're going to look for many of the same things. Now, true enough, you typically will not do lung function tests in infants, although I know that pediatric pulmonologists are able to do some passive lung function tests with babies, and that is certainly a very specialized test that they alone will do. But otherwise, you can still diagnose asthma in babies by looking at some of those hallmark symptoms. So babies can cough and not have asthma. Babies can wheeze and not have asthma. But if a baby coughs and it's a recurrent or persistent non-productive cough, again, that, if it walks like a duck and it quacks like a duck, so it's worse at night, it's accompanied by some wheezing, if they're coughing with exercise, with laughing or crying, if there's just a prolonged cough in infancy, and they're coughing aside from having a cold, let's at least think about the possibility, especially if they have a parent who has asthma. Wheezing, again, babies can wheeze and not have asthma because their airways are so small, so they can become compromised much sooner. That doesn't necessarily mean they have asthma, but if they have recurrent episodes of wheezing, especially if they are accompanied by these traditional asthma triggers, let's think about the possibility of asthma in this baby. If they have difficulty breathing, if they have reduced activity, they're not running and playing and laughing with the same intensity as other children. I was interviewing a mom once of a 3-year-old. I always try to get a sense of how active someone with asthma is, and they may not know what you're looking for or how to share that, but I just say, I would ask adolescents, are you able to run and play with your friends? Oh, I go out for football, or I do this or that. And I'll say, now, are you able to keep up with your friends, or do you sometimes have to sit on the sidelines and they pass you by and you have to take a break? Yeah, I really can't keep up with them as well as I would like to. Or I asked a mom, of a 3-year-old, what does she like to do for activity? What does she do to be active? And she said, well, we sit and we color and we watch videos and I read books to her. And I said, well, doesn't she ever run? I never let her run. If she runs, she starts coughing. Well, how many 3-year-olds do you know that don't want to run? I mean, that's their mode of action. They go from sitting to running in a matter of seconds. And you're never going to hear a 3-year-old say, Mom, I'm going to go for a run now. I need my medicine. I need pre-treatment. They're just on the go. So if parents are subconsciously or consciously holding back and restricting their child's activities because of fear of symptoms, that could potentially be asthma. And if they have asthma, that's not well-controlled asthma. 3-year-olds are supposed to run. Kids are supposed to be active. We expect children with asthma to be as active as they want to be. We expect adults with asthma to be as active as they want to be and as active as they should be for their age and their peer group. I had a woman in her 40s who was in the allergy office in tears. I've hung up my running shoes. I can't run anymore because of my asthma. And I said, well, get your running shoes out because we're going to get you running again. We just have to get your asthma. If you can't run because of your asthma, that's my problem as a nurse practitioner or provider. I'm going to help you get your asthma under control to the point where you can run and have a normal life again. And she did. She didn't understand, because when you start giving in and doing less and less and less activity, you become more deconditioned. And the more deconditioned you become, the more symptoms you have with less and less and less activity. So the goal is not to reduce activity. The goal is to get asthma under control so you can be as active as you want to be. So looking at activity in children, looking at past or family history, asthma in first-degree relatives. We're looking at asthma in parents and siblings. And then sometimes, if we can't confirm asthma by, say, a lung function test in an infant, we'll put them on a therapeutic trial of traditional asthma controller medicines, an inhaled corticosteroid. And if they show improvement on that, that is basically definitive of a diagnosis of asthma in that baby or that child, and especially if we stop the medicine and they get worse. So we're looking at something called the Asthma Predictive Index. And this, again, nobody has a crystal ball. It's difficult to tell because babies will wheeze or babies will cough and not have asthma. But we're looking for those babies who are at high risk for developing asthma. And those are those babies under 3 who have had multiple wheezing episodes in the last year. So 4 or more wheezing episodes. Some people would even argue for 4 more coughing episodes, but wheezing or coughing episodes that have lasted more than a day, have affected sleep, that baby or child is much more likely to go on to have persistent asthma after the age of 5. And after the age of 5, it's considered really to be lifelong. At that point, the thought is that if you have asthma into childhood and into school age, you're going to have it lifelong. You don't really outgrow it. You can just go perhaps into remission, but they're going to have it for life if they have certain criteria. So if that high-risk baby has had these wheezing episodes and they have a parent with asthma, that's a positive asthma predictive index. Or they have a diagnosis of atopic dermatitis or eczema, or they have allergen sensitivity. So they've been given a skin prick test or a blood test and they are positive to tree grass, weed pollen, dust mites, mold, cat dander, dog dander, etc. Or they have 2 minor criteria. They have food allergies, they have blood eosinophilia, or they have wheezing without cold. So any one of those, if they have a positive predictive index, they followed this birth cohort for 13 years. They found the majority of the children who were diagnosed with asthma after the age of 6 had a positive asthma predictive index before the age of 3, and the majority of children who did not have asthma after age 6 had a negative asthma predictive index. So it's not a crystal ball, but it gives us a sense of who might actually go on to have lifelong asthma. But in older children and adults, say 5 years and older, really the gold standard for diagnosing asthma is a lung function test that's called spirometry. And it looks complex, but it really comes down to about 4 different measurements, and I'll go through this quickly with you. We're looking at the volume of air that you can expel and the force of which you can expel this. So the FEV1 is called the force expiratory volume in 1 second. So if you think back to that grid that I showed you of the airways and what my airways are looking like because they're constricted right now, and it's going to take more time to get air through those very narrowed airways. So it's going to take me, I'm going to get out less air. Let's put it that way. I'll get less air out in that first second because my airways are constricted. So it's assessing the large airways. The forced vital capacity is when you take in a deep breath and blow out forcefully, it's all the air that comes out in that one forceful maneuver. So the ratio is really the key. Of all the air that you blow out in that maneuver, how much of it comes out in the first second? That's telling you the first horse out of the barn. And that really helps differentiate obstruction versus restriction. And then one more measure measures the small airways. So we're measuring the large airways, the trachea, the main stem bronchus, and then we're measuring the small airways. And putting all those things together will give us a really clear picture of what's going on inside the airways. Now, I've had some providers argue, I don't do spirometry in my office. I can manage asthma without spirometry. And I would argue, that I wouldn't think of treating someone with hypertension without checking their blood pressure. And I would argue that it's really difficult, if not impossible, to adequately manage someone's asthma without knowing what's going on inside their airways. And the best way to do that is with spirometry. And you can easily do spirometry in a primary care office and do it very, very well. And we're looking at the volume. So if you look here, this is what someone's normal volume might look like in time here, the FEV1. This might be someone who has asthma, so they're going to be getting less air out. And then after a bronchodilator, they get more air out. So it improves after the medicine. This is the flow volume loop. So this is expiratory, so they're taking a big breath and blah, 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 and then breathe in. And that's the inspiratory loop. And again, this is what a normal loop looks like. You can see this concave appearance here. That's classic obstruction. And you can see that that has actually improved after a BD or a bronchodilator. This is an actual tracing of a flow volume loop. So this little hash mark is the FEV1. And when I talk about when we blow out, if everyone took in a big breath and then blew out as long and hard and fast as you could, the majority of your air is coming out in that very first second. If your airways are not obstructed, you're going to get most of that air out in the first second. That's just the first horse out of the barn. It's all going to come out in the first second, and you can see very little of it comes out following that. So this might be me today because I'm still having some inflammation. You can see my FEV1 hash mark is probably not where it should be because these are predicted values up here, these dots. If I were to take a bronchodilator, wait 15 minutes and let the bronchodilator do its job and relax those airways, you're going to see that I'm going to move that notch a little bit here. Look how much more air I can get out in that first second after bronchodilator. If that improvement is 12% better after bronchodilator, that's consistent with the diagnosis of asthma. So we're looking for classic obstruction. We're looking at reversibility. Can we reverse that obstruction by 12% and 200 milliliters? Can we reverse the small airways by 25%? Those are classic findings for spirometry. So classic finding for baseline spirometry reveals obstruction. We would typically see that post-bronchodilator spirometry revealed reversibility, got better after bronchodilator. And even if the baseline spirometry is normal, you can still see improvement. We would have children come into the allergy office and they would have a history that seemed consistent with asthma. And we would do their bronchodilator, we would do this spirometry, they'd be at 100%. And if we just stopped there, we would miss asthma. We gave them a bronchodilator and repeated that same spirometry 15, 30, 20 minutes later, we might see the 100% go to 120 or 130%. You could still see a 12% or greater change if they have classic asthma, even on top of perfectly normal baseline spirometry. So if you stop at baseline and you don't do the pre and post bronchodilator, you could be missing many, many diagnoses of asthma. Usually in the office, the recommendation is at least one nebulizer treatment or 4 puffs of albuterol with a spacer, wait 20 minutes, and then repeat the same maneuver. Even if all of those normals are normal, even if all those values are normal, even if you don't see a change post-bronchodilator, that does not exclude the possibility of asthma. It may be cough variant asthma. You're not going to see a change necessarily on the spirometry. You can still do an inhaler trial and still see improvement. We're looking at these loops, and as I said, you can see this classic concave appearance here for obstruction. So when I would do a spirometry in the allergy office and I would go to the printer to pull off the results, before I looked at any of the numbers, I would look at the shape of the curve. And if I saw this concave appearance, I could see that it was obstruction immediately before I looked at any of the values. This is a normal shape curve here. And you can see this tiny curve. It looks very normal shape, but that's called restrictive. So someone would have a restrictive defect if they, for example, were morbidly obese. There's something restricting the rib cage or the airways where they just can't get, the air is coming out at a good rate, there's just less air coming out. My husband has a form of arthritis, so he's got sort of a fixed rib cage. So when he does spirometry, he has a very normal looking loop. It's just tiny because he has restrictive airway disease. And that's different from asthma. You can have a combination, but for asthma, we're really looking at obstruction. That's classic obstruction. So it really is important that whoever is conducting spirometry do it well. You need a good coach. You need good positioning. They need to stand or sit upright. It's almost natural tendency when, if anybody's ever done or seen spirometry done, you see people blowing and they're blowing on as hard and as fast as they can. And oftentimes they'll bend over at the waist because they just want to get every last ounce of air out. And that really is going to collapse some of those small airways. So you really want to encourage them to sit upright. You want the trunk upright all the time. You want the chin slightly elevated, the neck in extension. And it really takes a good coach. I always used to say that, you know, and the nurses in the office would laugh at me because they would say, I would say, if someone is standing outside the door when I'm conducting spirometry, if I don't sound like a fool on the inside of that door, I'm not doing my job, because it's going to be taking a big deep breath, put the cone in your mouth, put it between your teeth and your lips tightly around it, and blow, 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 blow. And I would coach them. I wanted the best effort possible, and that's really when you're getting the best results. Now, again, a normal baseline lung function does not rule out asthma. Even if it's normal, you still want to do a post-bronchodilator study. It's quite possible that their volume loops will improve after a bronchodilator trial. And even if not, if we suspect asthma, we can still pursue a medication trial. We can consider a course of oral steroids for 2 to 4 weeks. We can do a course of inhaled steroids. We can then have them come back and do another spirometry to see if that has improved on the medication. We're looking for improvement in symptoms and improvement in spirometry that's consistent with asthma. So once we made the diagnosis of asthma, now we need to know how severe asthma is. We really can't possibly treat asthma without knowing how severe it is. Just like with blood pressure, we need to know how severe someone's blood pressure, how high it is, before we know how to treat it. So we're looking at intermittent versus mild, moderate, or severe persistent. And these are based on 3 different age groups, but they're very similar. We're looking at daytime trouble, nighttime awakenings, frequency of albuterol use, how much these symptoms interfere with activity, and then in older children and adults, we're looking at lung function. And the reason for this is because we are going to marry that level of severity to the treatment level. So again, this line is the line of demarcation. You either have intermittent asthma or persistent asthma. And the GINA guidelines talk about how important it is for assessing, adjusting treatment, and reviewing the response. So we're going to diagnose, we're going to assess symptoms, we're going to assess inhaler technique, patient preference, we're going to adjust the treatments, both pharmacologic and asthma medications and non-pharmacologic strategies, and we're going to review their response. We're going to review symptom improvement, exacerbations decreased, no side effects, patient satisfaction, and has lung function improved. So these are the stepwise approach, and I'll take these one at a time quickly here. As we go up and down the step, we're going to look to see if we need to increase the level. That's doing that constant reassessment. We need to increase the level of treatment or decrease the level of treatment if they're doing well. Always thinking about if they're using their medications correctly, and always thinking about the environment. Asthma is one of the few diseases that is so interdependent on its environment. You really have to always keep the environment in the forefront. So step 1 is someone who has intermittent asthma, has trouble infrequently, a couple times a year. In between, they have very few or no symptoms. That's someone who could probably get away with carrying a quick relief inhaler with them at all times. Maybe they don't need to be on a daily controller medicine. But if they are having symptoms when the severity has been identified as persistent, that is someone who is having trouble a couple times a week during the day, a couple times a month at night. Not that frequently, but frequently enough that they need to go on a daily controller medicine. And what the guidelines are saying, the national and the global guidelines are saying, is that medication, that hallmark of daily medication, should be for everyone, regardless of age, from infants to 105, that medication should be preferred to be an inhaled corticosteroid. Now, you might want to start low dose and work your way up, depending on severity. If they have severe persistent when you're diagnosing, you might start at step 5 and work your way down, or start somewhere in the middle. But you're going to start with an inhaled corticosteroid. There are certainly other medications you can use, like a leukotriene receptor antagonist. We'll talk about all those in the medication webinar. But preferred is always going to be an inhaled corticosteroid. And as you go up the steps, you may add medications to that. like a long-acting beta agonist and other medications. But the inhaled corticosteroids, as you go up or down, will always be the mainstay. That is going to be the preferred long-term control treatment for all persistent asthma for all ages. Once someone comes back, what we're most concerned about then is not how severe asthma is, it is how well controlled it is. So now it doesn't matter how severe. I have, my asthma is typically very well controlled. I'm on 3 medications every day to control my asthma. So I would probably have moderate persistent asthma, but it's typically, other than when I get a virus, very well controlled. But you have to achieve all of these objectives to be well controlled. So you have to have fewer no daytime symptoms, nighttime symptoms, no interference with activities, infrequent albuterol use, and infrequent or no exacerbations per year to be considered well controlled. Otherwise, it's well controlled, not well controlled, or very poorly controlled. And again, just like with severity, depending on level of control, you're going to marry that to the step of pharmacotherapy. Now, in children, how do we assess control? Well, there's the asthma control test for children. This is age 4 to 11. It's been validated in ages down to 4. It is looking at I always call this the hemoglobin A1C for asthma. We don't have a hemoglobin A1C, but I use this because this is telling us how well asthma has been controlled in the last 4 weeks, validated for 4 weeks. So the child answers these questions based on how they're crying or smiling. How is your asthma today? How much of a problem is asthma when you run, play, or exercise? Do you cough? Do you wake up at night? The child completes these 4 questions. The caregiver completes the next 3. The highest possible score here is 27. And if we go back here, you can see a score of 20 and above is consistent with well-controlled asthma. 16 to 19 is not well-controlled, and 15 or below is very poorly controlled. So I would often, the nurses would give this asthma control test to the parents in the waiting room or when they roomed them before I came in to see them. I would have an asthma control test score, and I would know instantly where that child stood before I even said anything to them, and I would start from that point. For children and adults 12 years and older, very similar, it's just a little bit different because they can complete this themselves. 5 quick questions, the highest score here is 25, still scored the same way. 20 and above, well-controlled asthma, 15 to 19, not well-controlled, and 16 to 19, not well-controlled, and 15 below is very poorly controlled. So looking at these as well, and this will just, it gives you a snapshot of how well asthma has been controlled in the last 4 weeks. So the treatment strategies are to gain control. You want to be aggressive and get that asthma control initially to suppress the airway inflammation and get prompt control. We had a young boy who came in 3-4 years old, was in pretty rough shape, was wheezing, was coughing, was suffering for quite a while, came in to see the allergist for the first time, and was in rough shape. And we put him on oral steroids, inhaled steroids, and a couple other medications. The mom was in tears, and she said, I just want him to stop coughing. And I said, well, at this point in time, because his asthma, he has asthma, it's out of control, it's going to take this amount of medicine to get him under control. When he comes back, when he's doing well, we can peel away some of those layers of medicine, and we will step down his therapy. But this is what he needs right now. So we're going to maintain control, and we do want to step down, if we can, to maintain control with minimal side effects. So with someone who's well controlled, we're going to maintain them at that current step, or we can always consider stepping down therapy as well. So if someone has been doing well for a while, we're going to say at least 3 months, we can consider stepping down therapy. And I would often offer that to parents or to adults. I say, you know, you've been doing great, and you are on this higher dose of this inhaled corticosteroid. You've been doing well, no problems in the last 3 months. Would you be interested in going down to a lower dose? Or would you be interested in going down to fewer puffs or whatever? And sometimes they would say yes. Sometimes they would say, you know, she's heading into football season. Nope, I'm heading into my running season. I don't want to rock the boat. That's fine. If they're not well controlled, we're going to go up at least 1 step and reevaluate in a couple weeks, whatever it's going to take to get them under control. And very poorly controlled, that's where we're going to put them on probably a short course of oral steroids. But this is really the key, this statement down here. Before stepping up, we're going to check adherence and environmental control. So before I give someone twice the dose of what I've already prescribed, I want to make sure they're taking what I'm giving them. And that's where this comes in, this whole assessment, adjust treatment, and review response. So you want to ask your patients, are you taking your medicine? And you know, it's normal not to be adherent to controller medicine. It's normal. People don't want to take medicine, so they don't think they need it. And they may not think they need it. They may not recognize why they need it. They might get confused. I can't tell you the number of people that would come in and say, this is my albuterol. This is the medicine I take every day and it works great. And this is my inhaled steroid, and this is the medicine I take only when I really need it and I'm in distress. And they completely mixed up the roles of the two medications. So they didn't understand why they were taking one versus the other. So they need to understand why they're taking it. But then I would really open the door and I would ask them questions. I would say things like, how often do you take your inhaled corticosteroid, whatever the brand was? And they say, I take it every day, because they're saying things that they think that you want to hear. And I would really be surprised. I would say, wow, that's really great. You know, a lot of people forget to take their inhaler on a daily basis. So just thinking back in the last week, how many days do you think you actually forgot to take your inhaler? You know, opening up that door to say that non-adherence is normal too. And then you really would get the true answer for them. And then they would say, well, in the last week, I might have forgotten to take it 3 out of the last 4 days. So then you say, okay, that's fine. So help me understand why you might have forgotten to take it. And then you would really get to the heart of the matter. Are they truly forgetting to take it? Or are they fearful? I had a mom admit to me, I'm sorry, I heard the word steroids and I just froze. And I didn't want my daughter to get big muscles and a hairy chest. I'm not giving her steroids. And then we'll talk about this when we have our pharmacology webinar. But we talked about the difference between the anabolic steroids and the anti-inflammatory steroids. And we'll talk about the difference between oral steroids and the dosing of inhaled steroids, and set their minds at ease if we can, and address those fears, those very real fears that they have, because until you elicit and uncover those fears, they're not going to do what you've asked them to do because they don't understand or they're fearful. So it's very helpful to really get to those underlying concerns. If they truly just forget, then it's a whole other conversation. Well, can you keep this in your bathroom? Can you set a reminder? Can you set something on your smartphone to remind you to take it? So it really depends on why they're forgetting to take it. So has your asthma awakened you at night or early in the morning? Have you needed more rescue inhaler than usual? Have you needed urgent care? Are you participating in your usual or desired activities? What are your asthma triggers? And now consider whether they're taking their medication. So maybe they are being adherent. Maybe they truly are taking their medicines every day. Then the next question there is, show me how you use your inhaler. What you're going to see is probably going to be shocking to you. Even if you have taught them how to use their inhalers and you have observed them demonstrating that back to you, and the next time they come in to see you, it might be totally different, because those skills deteriorate over time. Those inhalers are complex, and I'm going to tell you, they're coming out with new inhalers and new devices every year. So if you think you have one down pat and they pick up a new script, it may be a totally different device, and no one has taught them how to use it. And if you don't teach them how to use it, whether you're talking to them over the phone or in the primary care office or in a specialty office, and the pharmacy doesn't teach them how to use it because they're assuming that you taught them how to use it, and no one is teaching them how to use it, they're left to their own devices, and they're probably doing it wrong. I had a woman who said she had a discus, and she said, this inhaler is just not working for me. And of course, we'd gone through it before, and she just forgot. She opened it, inhaled it, and closed it, and she never clicked it to activate it. And there's so many steps that can go wrong that if you don't review those steps over and over and over again, they're not getting the full benefit. And of course, if they're not using their inhalers correctly, they're not getting any of the medicine, potentially. So are they adherent to their medications? Because you don't want to prescribe twice of something they're not even using. Are they using their medications correctly? And then always, always, always look at the environment. You could have them on the best medication for that person. They could be completely adherent, using it exactly as prescribed. They could be using the perfect technique, and yet that person is going home and they're living with a cat that they're allergic to, or they're living with 20 cats and 2 smokers, or 20 smoking cats, or whatever their environment is. You just never know what people live like. And I would say to parents, especially parents who smoke, or even adults who smoke who have asthma, you are on the highly effective asthma medications, and I understand you're taking it regularly, but despite all you're doing, as long as you continue to smoke, it's going to be impossible to get your asthma under control and keep it under control, because the smoke is counteracting all the good the medicine is doing. So it's always going to be looking at the environment, whether it be animals that are allergic to certainly smoke, other triggers in the environment. And triggers is another webinar we'll talk about at great length in terms of allergies and fumes and smells, and one trigger we don't want them to avoid obviously is exercise. But there's so many, again, because asthma is so interdependent on the environment, we always have to look at what that looks like in terms of adherence, of inhaler technique and environmental mitigation as well. And we're going to step down therapy if we can, and if we can't, we'll maintain them, or we're going to step up as needed. So poor adherence, we just talked about that, is very common. It's estimated that 50% of adults or children do not take their controller meds as prescribed, and this contributes to uncontrolled asthma symptoms and risk of exacerbations and asthma-related deaths. So the contributory factors we talk about sometimes are unintentional. They just forget, they can't afford it, they get confused, they confuse the roles of the medication. It's intentional, they don't think they need it. I've had many people say to me, I was doing so well on that inhaler, I stopped it. Well, what happened? Well, then I crashed. Well, you were doing well because you were on the inhaler. You know, it's counterintuitive for someone to take an inhaler every day when they're feeling well. It's just like blood pressure. You don't necessarily feel it when your blood pressure is high. Why am I on this medicine when I don't feel any different when I'm on it, when I'm not on it? When you go off the medicine, then you're going to feel it. They fear side effects. And then we talked about how to identify low adherence. Would you say you're taking it 3 days a week or more or less? Open up that door that non-adherence is normal, and I don't want to hear what you think I want to hear. I want to hear what the truth is, because that's the best way I can help you and I can address what your concerns are. And then you have the ability sometimes to check prescription date. You can certainly check refills, and then always address their beliefs and their concerns about the medications. There's a few interventions that have been studied closely in asthma, have been found to be highly effective in improving adherence. That's that shared decision making. So I would say to individuals with asthma, you know, we have the option here of adding this medication or that medication, and where do you feel this would work best for you? And inhaler reminders for missed doses, and review their dispensing records as well. So the essential components are using their skills, encouraging adherence, asthma information, and guided self-management support. So we know that these are highly effective in improving asthma outcomes and reducing hospitalizations, ED visits, symptoms, nighttime awakenings, time off of work, improved lung function, quality of life. We're going to self-monitor. We're going to have a written asthma action plan. That's another webinar. And we're going to perform regular medical reviews. I'm going to conclude there. I know we are just at the tail end of this. I had a lot more information to provide today. That's why this webinar ran a little bit longer, because I did want to incorporate some of the 2017 pieces to this as well. And I think we have just a couple of minutes left for questions. I'd be happy to take those at any time. Thank you very much for your attention today.
Thank you so much, Karen. Really appreciate the great information as always. So we are going to prepare to unmute the line. So before we do that, as a reminder, if you're on a conference phone and in an area where there's lots of noise, please mute on your end so we don't hear that information. Please, as a reminder, do not have any conversations with folks in the area about patient information related to some of the HIPAA. And some logistics. One, there are continued education here for the nursing and social work. So you should have received upon registration email to the evaluation, and once you complete the evaluation, then you'll be able to get to the certificate information. So those are just some logistics for if there are medical assistants on the line. If you copy the agenda and the certificate of participation, you'll be able to use that for your continued education requirements as well. So with that, we'll open it up, and any questions for Karen?
Karen, this is Christine.
Hey, Christine.
Will we have access to this presentation?
Yes, I believe it will be archived on the Mi-CCSI website, correct, Sue?
Yeah, so we did record the webinar, and we'll be putting that on the website. So if you go to www.mi-CCSI.org, same place where you went to register, the recording will be available there, as well as the PowerPoint. It usually takes us about a week before it's there, so it's about a week before looking.
Thank you, and I'm going to admit that I did not register before attending. Is it possible to do a late registration?
Yeah, so for folks that did not register, go to the website again, www.mi-CCSI.org, complete the registration, and it will also be sent to everyone and evaluation certificate.
Thank you.
other questions for Karen? Well, maybe Karen, while we're waiting for folks to pick up questions, one of the things that I'm reminded of the value for case managers is in the implementation phase where we're doing follow-up and monitoring between visits with the physician. And it's so key to know what to include in that assessment. Do say the doing either the ACT or the PACT is a good way to and the person management between visits. Are there other things we should pay attention to?
There's a lot of reverberations too. It's hard to understand.
Okay, so we're going to try this. So we muted folks. Are they muted? Yep. Okay. So everyone should be muted. So maybe rather, if you have questions, send your questions in through the chat. But the question I had, Karen, was in the implementation in the case management process. That's the follow-up and monitoring.
Yes.
That's between patients' visits with the provider.
Mm-hmm.
And one way to determine, gosh, how well is the patient doing with managing their asthma might be using the ACT or the PACT.
Correct.
Are there other things that we could use to really determine how well the patient is doing?
Yes. Well, I would look at a couple things, and we'll talk about this when we get to the pharmacology webinar too. But certainly the asthma control test is going to give you a sense in the last 4 weeks how well that patient has been doing. And a couple other things you can look at would be the rules of 2, and we'll talk about that in the pharmacology webinar. And that is, are you having daytime symptoms more than twice a week? Or so are you using your albuterol more than twice a week? Are you waking up at night more than twice a month? So twice a week daytime, twice a month nighttime, and are you refilling your albuterol more than twice a year? So we're looking at those rules of 2. So if you are writing a script for albuterol, typically when I would write one in the allergy office, I would write a script for albuterol with 1 refill. And if that family would call back within a year for another refill, you know, now I would certainly give them, if they were using maybe 1 for mom's house or dad's house, or 1 for work and 1 for home or whatever, that's one thing. But they truly are going through more than 2 albuterols a year. At that point, we would say, you know, this is your 3rd refill for albuterol this year. Why don't you come in and see us and let's find out what's going on with your asthma? Because that's a lot of albuterol. There's 200 puffs in every one of those canisters. So if you're needing more than 200 puffs more than twice a year, there's probably something going on. So tracking albuterol refills, the rules of 2, the asthma control test scores, and then having a very robust asthma action plan that you can review with that patient every time they call in. They're having symptoms. Okay, you're in the yellow zone. Have you done A, B, or C? Where are you in the scheme of things here? And we'll go through that when we do the the asthma action plan webinar.
Okay, we did have a question from chat. They're having problems accessing the evaluation. So we will go ahead and we'll re-email the link, make sure that it's working properly, and re-email it to you. So if you did not register, please make sure you go to our website and register for this so that we can make sure that we can get you the right link to the evaluation.
Okay.
Any other questions that people want to submit through chat for Karen? Well, it doesn't look like there's anything coming through, so thank you, Karen. And if you would like to attend any of the other webinars, please make sure you go to our website, www.mi-ccsi.org, and register for the following webinars. Our next webinar will be next Monday on October 20th, so we hope to see you there. And thank you for attending today.
I think it's next Monday, the 23rd. Is that correct?